Okay, gang, let's finish up here with our gas exchange exemplars, and let's talk about ARDS. ARDS stands for Acute Respiratory Distress Syndrome. So as you may have guessed already, it has to do with respiratory distress, and it happens very fast. So ARDS is also known as shock lung, stiff lung, white, wet, or Da Nang lung. So shock lung means basically the lungs go into a state of shock. Stiff lungs, because of the inflammation and fibrosis, they become stiff, lose compliance. White, meaning, as you can see here on this chest x-ray, they're completely whited out. If you look at a normal chest x-ray where the lungs are open, they'll be nice and dark like this here, showing air in the lungs. But these are a white lung. I don't know, I didn't look up what Da Nang lung means, but what wet refers to the pulmonary edema. So this is a non-cardiac caused pulmonary edema with refractory hypoxemia. What does that mean? So this means that unlike CHF or any kind of heart failure, the pulmonary edema is not coming from the heart. It's not cardiac caused. It's simply located in the lungs, period. The other thing is refractory hypoxemia. Remember that we talked about hypoxemia as being low blood oxygen or low arterial blood oxygen levels, or PaO2 is low. And when we have refractory, it means that we can administer oxygen all we want to, but because there's a problem with the alveoli themselves, it doesn't matter. It's not going to do anything. So we administer oxygen to no effect, basically. And then, again, this is a severe, it's acute, but it's also very, very severe. Like, this is the most severe form of respiratory failure. And this is because it happens very rapidly. It can happen within 90 minutes to 24 hours within first injury, or when the lungs are like, start to freak out, basically. So it happens very fast. Also, it's hard to diagnose. It could be many other things causing the symptoms. They're very nonspecific. So the best thing that we can do is, as nurses with ARDS, is to make sure that we are recognizing our patients that are at risk factors, just like with pulmonary embolism. High mortality rate, between 50 to 70% of people diagnosed with ARDS die from it. So the best thing that we can do is, again, let's recognize our patients' risk factors, make sure that we're doing excellent baseline assessments, knowing what their normal is so we can intervene rapidly whenever we see changes. So, what causes ARDS? So, remember, the thing about ARDS is that it is not a primary process. And as I have written down here, this means we don't go from being a healthy individual walking down the street to all of a sudden we're in acute respiratory distress syndrome. There's some kind of precipitating factor. It means something happened that causes, like a domino effect, if you will. So there's nothing directly related to ARDS where all of a sudden the lungs go into shock. Something happens first. These are all the different things that can cause, that are risk factors, if you will, that can precipitate ARDS. Septic shock is huge. It's one of the leading causes of ARDS, and it's incidentally those who develop ARDS because of sepsis have the worst mortality rate. So diffuse pneumonia, especially viral pneumonias, already having some kind of infection in the lung, anaphylactic shock, overdosing on drugs, drug reactions, just idiosyncratic ones, meaning they happen for no particular reason, to ampicillin and hydrochlorothiazide, direct injury through inhalation of noxious gases such as nitrous oxide, ammonia, chlorine, near drowning, again, direct injury to the lung, O2 toxicity, acute direct injury to the lung, aspiration, acute, that's acute direct injury to the lung, multiple transfusions, that's indirect injury, open heart surgery when you're doing cardiopulmonary bypass, direct injury, hemodialysis, indirect, leukemia, and then there's a couple other ones listed at the bottom of the slide in the notes. So why? Why does this happen to the lungs? So remember that we talked about the function of the lung is for gas exchange, but the way that the lungs are built is that they have a filtering system and a system where they move, immunity system where they move things that are inhaled out of the lungs. But this means that any kind of inhaled irritant or pollutant can cause, if it makes it past the filter, and it's enough, overwhelms the immune response, can cause direct injury to the lungs. The other thing is, remember we talked about in our overview video that lungs are very, very vascular. So anything that's circulating through the blood, especially with sepsis, remember sepsis means that we have an infection that's made its way into the bloodstream. This nasty inflammatory brew or blood is basically being carried downriver where it always goes, which is into the lungs. It goes into the right side of the heart. It makes its way into the lungs, and that's our normal body circulation to make sure that it gets perfused. But in this case, it's carrying all this nasty stuff along with it. So the river's polluted, if you will, and as it passes by and gets into the lungs, where that, again, remember those membranes are very thin because we want gas exchange to happen. They're very vascular because all the blood needs to go through there. We can get indirect injury to the lungs. So what happens? Well, basically, there's this infected brew in the blood, or direct injury to the blood, to the alveoli themselves through inhaled pollutants or irritants, can damage the alveolar capillary membrane. So there's a thin membrane, remember, between the alveoli and the capillary beds made up of type 1 epithelial cells that gets damaged. And due to the damage, fluid fills up those alveoli, causes the lungs to become less compliant. You can look at the review video for compliance, and we end up with fibrosis, and this all leads to hypoxemia, low blood oxygen levels, respiratory acidosis, and metabolic acidosis. That's the end result of this. And a little bit further down here, we would see death if untreated. So what's going on at the cellular level? Remember that in the law of physics, it's Newton's third law, for every action there's a reaction. So every time something happens, whether I'm moving my hands as I'm talking, if I'm doing that, there's a reaction in the air where gases and air is being moved by my hands. So the same is true in our bodies. Every kind of action that's taking place results in a reaction. And in this case, the injury to the lung is overwhelming, and it's enough of a gut punch or a sucker punch, if you will, that it causes a capillary leak. So remember, we're talking about the thin membrane between the alveoli and the vasculature, where perfusion is happening. So we've got a capillary leak there. Capillaries burst, they leak. This causes vasodilation. And when all of this happens, capillary leak and the vasodilation, all the fluid and protein begins to pour into the basement membrane part of the vasculature. So the outside walls, if you will, of the vasculature start to flood, or the basement gets flooded, if you will. So remember, protein's very large, and the second it gets a chance to get out there and see the world, it jumps out of vasculature. And in this case, it's only going to make it as far as the basement membrane. So we're not going to see, like when we've talked about some other things, it's not going to make its way into the tissues all over. This is only happening in the lungs. So you're only going to see the pulmonary edema from this. So we have an injury, immediately the capillaries leak that cause vasodilation, and then vasodilation waves and it says, hey, we need help here, we're drowning. And so the inflammatory cascade is like, I'll come to the rescue. So the neutrophils show up, the cavalry arrives with its mast cell friends, and they're going to help out. But because there's this massive leaking into the tissues, and the injury is continuing to happen, it's already been started, this domino effect. We not only have massive fluid, but now all these neutrophils and mast cells, and they pour in there too, and we get massive inflammation. So we've had edema, and now we have massive inflammation. So fluid and the basement membrane, or the membrane itself, becomes inflamed. So the other thing because of the inflammatory cascade and the inflammation, this begins to damage the type 2 epithelial cells. Remember that those play a role in producing surfactant, and surfactant is what keeps the alveoli open. So not only do we have this flood of fluid into the basement membrane and into the alveoli, but now we also get these cells are getting damaged and not producing surfactant and not keeping the alveoli open. And this can happen not only in the flooded alveoli, but also in its brother or sister kind of neighboring cells, or alveoli. And then the vessels begin to get scarred, and this reduces diffusion capacity. And remember that we said diffusion capacity is the ability of, that's how gas exchange takes place. It's called diffusion across the membrane. So now we're going to have reduced gas exchange. So in summary, what this means is that we have decreased diffusion. Decreased diffusion means less gas exchange. This means that we're not going to be able to get, we're going to have perfusion, because remember that blood's still circulating, but there's a problem in the alveoli now, so we're not going to have ventilation. So this means that there won't be, even though CO2 is being brought for pickup, it's not going to be picked up because we don't have ventilation. So this is going to lead to hypoxemia, which is going to lead to hypoxia. Then we've got that flooded alveoli, which I just kind of alluded to, which equals a shunt. Remember, we said that a shunt means that we are perfusing down here, blood still flowing through like it's supposed to be, but due to the massive inflammation and leaking here of this membrane and the fluid buildup in the cells, and perhaps collapsed alveoli due to the lack of surfactant, there's no ventilation coming to the alveoli. So we're going to end up with a VQ mismatch. So then our ventilation is, instead of being 4 liters per minute, is going to be very decreased, while we still have a perfusion of approximately 5 liters per minute optimally. So we have a VQ mismatch. Then, because of the stiffening that starts to happen, because the lungs are so stiff, there's no surfactant, we will get stiff lung, which means that we have decreased compliance of the lungs. Then over time, the body has recognized, okay, we've had this leak, we've had an inflammatory process, and remember that the body also reacts to injury by trying to clot it off. And the first thing that arrives is fibrin. And so fibrin arrives and starts making, in here where all this swelling is happening, decides to start trying to form a little blood clot and wall this stuff off. Well, fibrin means that we're going to have permanent and irreversible fibrosis when fibrin shows up. So it's very, very important to note that we can correct this diffusion problem and correct the hypoxia. We can get rid of the flooded alveoli. We can help correct this VQ mismatch, and we can help with the surfactant issue and the swelling, but we cannot do anything about the fibrin that develops in the basement membrane. So the longer that a person stays with these 3 above issues, or with this cellular damage continuing to happen, if the cellular process is not reversed and stopped, the person is going to end up with irreversible fibrosis, which means chronic hypoxia. And if this happened, and say we finally recognized it, we got the patient on a ventilator, this patient's probably not going to come off the ventilator, because there's going to be permanent irreversible fibrosis and permanent decreased compliance. Okay, so there's a great video in here that I would love for you to watch, and it pretty much just reviews that again when I went over at the cellular level, but he draws some pretty pictures. And then this is showing the alveolar changes in ARDS and each phase that we talked about. So this is our initial phase of injury, and then we have an increase in the capillary permeability, which means that the fluids shift into the basement membrane. Look at them all going down there into the basement. The basement starts to flood, and then the upper floors start to flood. Look at that, we're starting to get pulmonary edema, and then we now are having a problem with surfactant. We can't produce anymore. The alveoli are starting to collapse. Think about buildings being flooded and then collapsing. So this changes lung compliance. And then we get an issue with our or shunt, okay? So that's the problem here, on a pathophysiologic level, what's going on in ARDS. In our next video, we'll talk about clinical manifestations and nursing treatments, diagnosis.